This is Rich Salama, and today in the 5-minute lecture series, we're going to be going over asthma. So, what is asthma? Asthma is essentially a hyperreactivity of the bronchial smooth muscle to allergens. This is usually IgE mediated, and it leads to edema and swelling of the airways. The most common triggers, as you see up here, allergens, viruses, cold, irritant, exercise. Ultimately, this will lead to some chronic inflammation and tissue remodeling, which leads to that bronchial smooth muscle hyperplasia. Remember, this is mast cell mediated. But the main thing that you have to remember about this is that in comparison with COPD, this is actually a reversible process. COPD will have minimal response to bronchodilators, whereas asthma has really, really good response. So, in terms of the stages of this disease, it's along a spectrum, but I'm going to use the ABG just to kind of show you how it works. So in this stage 1, you've got a very normal person who is not currently experiencing an exacerbation. Their PCO2 roughly around 40, and their PO2 is at the normal range of 70 to 100. That's fine. But then once they hit the allergen exposure, they don't feel so good. So they start to hyperventilate, and because they're hyperventilating, their CO2 starts to drop off, as would be expected. And then their PO2 drops off as well because they're having bronchospasm. And then as they get along the third and fourth stages of the disease, these people are really hanging on for dear life. And so what happens is, as they progressively begin to have respiratory failure and they begin to wear out, their CO2 is going to gradually climb, and their drive to breathe is going to drop as well, and so their PO2 is going to drop off quickly. And what you have to remember about these particular patients is that even if they have a normal PCO2, if they look like they're working hard to breathe, a normal PCO2 can actually be discouraging, or it can be a very bad or ominous sign, because these people could be on the brink of respiratory failure. So at any rate, let's just jump right into it. This is your patient. So we'll say that she's 3 years old. She's not responding to her home treatments of nebulized albuterol. She has a respiratory rate of 40, tachycardia to 150, afebrile, and an O2 sat of 87% on room air. Now let's just presume that this is an asthma exacerbation. So the question is, what do you do for this? And the answer is not to just sit there and say, let me go and check my physician's desk reference. You want to be able to have a good idea of how to treat these, because these patients are at very, very high risk of decompensation. So, first line treatments. Oxygen is always a good thing to give somebody who has a low oxygen saturation. So you can start there, and you want to titrate them anywhere just above 90% usually. You want to go ahead and give them some beta agonists, 5 milligrams for adults, 2.5 milligrams for pediatrics. These can be done continuously, or they can be done every 20 minutes or so. And anticholinergics, your ipratropium or Atrovent, that is usually mixed in with the albuterol, so you can give that at once. It's usually 0.5 milligrams or 0.25 for pediatrics. And then all of these patients will get corticosteroids of some type, and the benefit of these is not immediate, but within 4 hours or so, you're going to get some significant response in terms of the inflammatory response going on in the airways. So those are very good to give. Usually Solumedrol 125 milligrams for adults, or Decadron 10 milligrams for most children. Kids under the age of 5 are generally dosed on a weight basis, which we're not going to go over. And then magnesium does have some benefits. So this is kind of getting into the patients who are not responding to any of the treatments above, but it is a useful second-line treatment. So let's just say that you give all those treatments and none of them are working. The next step is to really start worrying about this kid and considering whether or not they're going to be needing treatment in the ICU. So the next step is non-invasive positive pressure ventilation. Just like in COPD and CHF, this can be an excellent adjunct to save these people from intubation. So that's about all we're going to into, but just know that NIPPV, non-invasive positive pressure ventilation, is very, very useful in this particular situation. Ketamine. Okay, so ketamine, the reason that it's useful is because it is actually a bronchodilator, and this is not something so much that you just give as a single agent, but perhaps something that you're going to give before you intubate them to give them the best chance. Or you can do something almost called delayed sequence intubation, where you would give them a subdissociative dose of ketamine and then allow them to breathe on the non-invasive positive pressure ventilation. And then there is some small amount of evidence to epinephrine in these patients. You can give them a little bit of an epinephrine drip if everything else is failing and they're crashing. But generally, if they're at that point, then the last thing you want to do is intubation. And the reason this is not so good is because they tend to have a very hard time coming off the vent usually. And most of them will usually have to be in the ICU if that's the case. And so let's just say that you did all the above and your patient is happy and you know that she's looking pretty good. What are the disposition of these patients? So, usually if these patients turn around and they have good oxygen saturations, they're not requiring supplemental oxygen, most of them can go home. If they are having increased oxygen requirements and or they are still in mild respiratory distress and still requiring continuous O2 despite your maximal treatment, a lot of these patients will end up on the ward. Now, if they are going to go to the ICU, usually these are the patients that you've intubated or are having on continuous nebulized albuterol on non-invasive positive pressure ventilation. So really 3 completely different dispositions, all based on how your patients look. And that is it. That is asthma in a nutshell. I hope you've enjoyed this, and we will see you next time.